what we're doing here today is talking about the screening of the fetal heart. So this is different than a fetal echo exam. And the terminology has been very confusing for many years, and as our teaching of the fetal heart has evolved, we've really come a long way in trying to distinguish. At first it was this no man's land. Who is supposed to look at the fetal heart? You know, should it be pediatric echo people, or, you know, the cardiology group kind of wanted their area, but they don't get them until we find it in our OB world. So it's always been this kind of no man's land, and who should know it? It's been a weird area. You know, it's not like the OB and stuff. We all get taught a lot about that in school, but the heart has always been kind of difficult. And then there's always been this question of, what do you have to do? What should we do? Because in our second trimester exam, so the screening of the fetal heart is what we do during the second trimester exam. So we're talking what? Anywhere from 16 to 25 weeks, usually 16, which is horrible. You know, we're hoping for 20. And I prefer like 22 or something, depending on your body habitus, because that can be a real problem. What we're talking about here today is not doing a complete fetal echo exam. We're not talking about Doppler, and we're not talking about those kinds of things. One of the distinctions that I really want to make here is this is the screening exam. So this is what we want to do during every single exam. And there are the guidelines that have come out, the AIUM guidelines come out, and they're not very specific. Okay, they just say outflow tracts, LVOT, RVOT. How do we know what views we should be taking? So the AIUM practice guidelines, that's our Bible of where are we going, right? What's our standards that we look for? We look to the AIUM. In 2013, as probably most everyone knows here, they upgraded them to include the LVOT and the RVOT. So it used to, under chest, it used to say heart. So which always makes me wonder, why doesn't it say lungs? Because it doesn't. So the AIUM is awesome, but they're not one to say every little detail. So I'm here to say it's okay to do this, 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 and this. And why? The screening of the fetal heart is performed during the second trimester anatomy scan. It differs from the complete echo, as the purpose of screening is just to determine whether or not the fetus needs to be referred for further investigation in order to prepare for delivery. Okay, that's our job. Find it. No one else is going to get these kiddos if we're not finding it. So the cardiology people might be really phenomenal at doing all the Doppler and everything, but they're not getting them unless we find them. So normal anatomical relationships must be determined. We have to say, is this okay or not? But deciding what type of a defect or anomaly is not what we're going to be doing here. We don't have to know this is a double outlet right ventricle. That's not what we're going to be learning, and it's not our role. What views do you take? There's a million of them. So if you go to the AIUM fetal echo area, AIUM will have your OB guidelines, and then they actually have fetal echo guidelines, but that's for the full shebang. Okay, that's for doing a full complete echo. So they will show you all of these views. Okay, here's our arch views, here's a short axis high view, here's our 3-vessel trachea view, here's our arch view. In our 35 minutes to 60-minute time frames, how are we going to get all these in? So how do we know what views we're going to do for screening? Here's how. There are articles that are coming out now speaking about screening. When you see the word screening is now a recognized word. We're talking about fetal echo, and we're talking about screening. Then there's this fetal heart term in the middle, which we don't know which way that flies. So the International Society of Ultrasound and OBGYN, they've been around a long time, and they're pretty much based out of Europe. And they do a lot of your guidelines. So it's this international society. And they publish a journal, kind of like the AIUM journal or the SDMS journal, and it's called the White Journal because it has a white front, okay, very scientific. And they came out in 2013 with guidelines that they updated, and they actually use the word screening. These ISUOG guidelines are going to tell us what we should do, okay, because we should be practicing current standards of practice, right? What we should do for screening. Everyone knows we don't have a million, minutes to do these scans, and there's a whole lot of other things that we have to be looking at. The heart, while it is the largest area of concern in a fetus, we have to look at everything from toes to the brain anatomy. So we have X amount of time. In these guidelines, these are the words they say. Performing a transverse sweep, the sweep technique, with cephalad movement of the transducer from the fetal abdomen at the level of the abdominal circumference through the four-chamber view and up towards the mediastinum offers a systematic way of assessing the fetal heart and provides the various ways through which normalcy of the outflow tracts can be ascertained. That's right in their guidelines. That's right what they say. So then they show this picture, and they say we can do what we need to do in screening with 5 transverse views. That's what we're going to be talking about. These happen to be, this looks like, this is actually one view, 2, 3, 4, 5. One side of this card is the 10 things that what I'm going to cover in this lecture. 10 things from ISUOG guidelines that I picked out that you need to look at just in the four-chamber view. Okay, so now this gets a little overwhelming because 10 things in the four-chamber view. Yep, but that's what this first talks about, okay? And then these are the other views that we're going to talk about in the next lecture. So these are the views, transverse, okay? They can all be done transverse. We're not going to do arch views. We're not going to do, those are sagittal. Okay, we're doing 5 transverse views for screening. Transverse abdominal view determines situs, very important. Four-chamber view, LVOT view, RVOT view, and interestingly, 3 vessels and trachea view. Notice we're not using the term 3-vessel view. These have been very confusing, I think, for sonographers, so it won't be at the end of this. If you look at the AIUM fetal echo guidelines, now this isn't screening, AIUM has fetal echo guidelines, okay? They also talk about these 4 views plus situs. They also then go on to say all the other views that you would do in a full echo. Where are we going to start? We always are going to go back to the basics. Fetal heart anatomy and physiology, and this is, believe me, 101, or whatever's lower than 101. Okay, this is very basic, what I think we have to kind of get a little bit that we may not have gotten in school if we even went to school, depending on how old you are. This is the heart. So very early, at about 20 days, we have 2 endocardial tubes. They're separate tubes, and they fuse into one. This is what's happening. Now we end up with 1. We have this lower area, kind of, it's going to be more inferior, okay? Then we have this area that's going to become the ventricles. This is going to become the atria. Then this is called the bulbus cordis area. Then this is called the truncus arteriosus area. And then we have a couple of these remnants of the tubes still here. Now, the white is the pericardium. So the pericardium is there, remember, it's the sac. So everything has to happen within the confines of this pericardium. And it starts to elongate and dilate and buckle and loop, and all of this happens within the constraints of the pericardium. Notice 20 days, 21, 22, and 24 days. That is a whole heck of a lot of stuff to get done in about 4 days. There's a lot of stuff going on here. Here we have blood coming in the bottom, and it's swishing around through one big chamber, and it's going out the top. Now, all of that has to form into the intricate heart. And part of the forming is this looping of moving around of this structure. In the middle, it needs to do this. And that's how our ventricles end up on the right and the left side. So it's very important. So sometimes you will have looping defects, and it just didn't do it. It decided, I'm only going this far, I'm not going this far. or whatever. So sometimes you'll hear the word, we don't need to know what they are, but looping defects, and that's why. It didn't loop right. So then, now we're at this 24 day, and the top of this area, top of the heart, this tree trunk that's coming off the top of the heart, is still one big tree trunk. It's called the truncus arteriosus. And very early, it has 6 pairs of arches coming off it through a very elaborate process of regression, anastomosis, division, persistence, every other word you can think of. These 6 pairs of arches form numerous vessels up in the top, very complicated, which is why it's easy to get an anomaly of these great arteries, okay, because there's a whole lot going on here. So they form vessels including common carotid, aortic arch, pulmonary arteries, and ductus. Many defects of the great arteries being the aorta and the pulmonary artery, arise as a result of the persistence of these. Sometimes they don't go away when they're supposed to regress, and they persist. Sometimes they go away too much, and now you have an arch that's teeny. It didn't open up enough, or whatever. All kinds of things can happen. This is a process that's going on at this time. Then we get to, here's these arches. Now notice now the bottom part of this area is going to be the atrium. That folds up underneath. So now we have atria, blue in the back, kind of more posterior. This ventricle's kind of a little more anterior, and this big tree trunk coming out of the top with all these arches. Now these arches have done their thing, and now we end up with just one big tree trunk coming out of it. This is called the truncus arteriosus. Very important area. This needs to divide into the aorta and the pulmonary artery. So it starts out with all these vessels that all of these have turned into, all of these carotids, pulmonary arteries, and everything else. It's all kind of coming off here, but there's still one. Then you have this ridge of tissue. Here we have this big tube coming out of the top, and then things are going all over the place. This big tube has tissue that grows in the middle, okay? And it grows in a spiraling fashion. Kind of, it starts to grow here, and then it grows here, and it ends up turning like this. This is huge. This is really big. When they don't turn, if they grew together, but they didn't turn, you have transposition of the great vessels. If they turned a little bit but not enough, you might have a big VSD in there. We don't have to know all of that. We have to know what we have to look for. So in the truncus arteriosus, this is what we have to say. Did it split? Is the pulmonary artery and the aorta coming out of the correct ventricles? That's what we need to do. Is there a hole at the base of this truncus arteriosus, a VSD, which tells me it didn't turn around all the way? That's what we have to look for. We need to end up and be able to say, yes, this appears to be, from what I can see, a normalcy of how these vessels come off and how they split. And then we end up with this. So here again, here's our big truncus arteriosus coming off. And it is now spiraled up. And the anterior part of that spiraling, okay, the anterior part, it's just one vessel that splits in two. That's why they're, like this. The anterior part aligns itself with the right ventricle. The interventricular septum is growing up the middle during all this. The posterior part of the spiraling aligns itself with the left ventricle. Blood should not go to the other ventricles. So if the septum aligns itself with this septum of the truncus arteriosus, this is the perfect situation. Now blood from the right ventricle goes out the pulmonary artery, it twists around and goes off into the pulmonary branches. Blood from the left ventricle goes more posterior, okay, back towards our spine, underneath here, and then comes up, and now we're going to end up a little bit on top, and then we go up to those vessels. Kind of get that? That's just a really important concept to get. We don't have to memorize it, we just have to get it. So while all this is going on, now we still have blood coming in the bottom and then going out the top. So septums have to divide. So the chambers have to divide. We have now atria and ventricle, kind of, but we don't have the septum. So these septums grow in very complicated, especially this atrial septum. It's very complicated. But we just have to know that they kind of grow in and divide the two sides, the right and lefts, from each other. So this is how that kind of works. At the end of the 4th week, we're still very, very early. Many people don't know they're pregnant yet. 2 mesenchymal cushions, they call them cushions. It's blobs of mesenchymal tissue that kind of grow a little faster than other things. That's definitely less than 101. At the end of this 1st week, the atrioventricular, okay, when we talk about the words atrioventricular, from the atria to the ventricles, between the atria and the ventricles, so what are they? Your mitral and tricuspid valves, right? That's what's between them. 2 mesenchymal tissues come in, and the atrioventricular endocardial cushions appear at the borders of the atrioventricular canal. So your atrioventricular canal is the areas, here's your atria and here's your ventricles, okay? Your canal is in the middle. These tissue grows in to separate, number one, we have to separate left from right, and then we have to separate atria from ventricle. So this tissue grows in, your endocardial cushions come in, and eventually we have a right atrioventricular canal and a left atrioventricular canal. This is so important because this area of the heart we have to look at. Look how intricate that is. What can go wrong here? A million things can go wrong. And what goes wrong at this spot often is endocardial cushion defects, highly associated with trisomy 21. Okay, why do we care about that? Because it's our most occurring chromosomal anomaly, right? So what are we going to see? We're going to see these more than we see some other things, these endocardial cushion defects. Then, during all this, or sometime during this time, the valves develop. So now again, these are teeny, not even a millimeter thick. And so can you imagine? These start out with thicker tissue and then they have to absorb down into teeny little flaps. What happens when something goes wrong with that absorption? They stay thick. They absorb too much and we don't have 3 leaflets or something like that. All of this stuff is going on that we have to then say is normal in an average of 45-minute time frame while we look at 50 other things in the fetus. That's why we're simplifying the screening exam to 5 views. And these 5 views that we're talking about can be done in still frame images. Now that isn't ideal. No one that does fetal echo would say use still frame images because you have to, there's a lot going on in this heart. There's a lot of contractility and everything else. We have to come up with a way to figure out these 5 images and all the stuff. Of course, there's 10 things to look at in the 4th chamber, all of that, and we have to do them all in a way that a radiologist or MFM or who's ever OB, who's ever reading your stuff can quickly look at. They don't have 10 hours to look at it either, which is a clip. A whole lot of information in that clip. Would we love that? You bet. You do a fetal echo and it's all done in clips. But this is screening. So what we are saying is you can do the screening with these 5 views. So now we're going to look at the valves. The other thing, how many of you routinely evaluate for pulmonary veins? Okay, this is something that we have to start looking at in the 4-chamber view. So our pulmonary veins, what do? They come, 2 each, come back from the lungs and bring the blood that's oxygenated, after birth of course, oxygenated from the lungs and get them back to the left atrium. So initially, a single pulmonary vein enters into the left atrium, divides into a couple of branches, and then they keep dividing again in 101. This is what happens. Then, gradually, these kind of go apart, and it forms a smooth part of the left atrium here. Okay, forms a back wall of the left atrium, and we end up with pulmonary vein here, and then they split. So eventually, we end up with 2 pulmonary veins coming in on one side of the left atrium and 2 coming in on the other side of the left atrium. The problem is occasionally these pulmonary veins don't want to behave. They're like a 2-year-old. They say, maybe I'll just hang out back in this back area and I don't want to join. So now we're talking about an anomalous pulmonary venous return. So we're going to talk about that too. All right, how do we get the job done during screening? These 5 axial views that we're going to talk about. In this lecture, we're going to talk about determining situs and the 4-chamber view. The others, the outflow tracts, are the next lecture. So let's go. First of all, determine situs. And determining situs is actually a part of what we're supposed to be doing when we look at the stomach. When you look at the AIUM guidelines under abdomen, what are we supposed to evaluate with the stomach? The presence, size, and situs. How many of us have been doing that? Well, you don't really think about it very much before we start talking about the heart. Let's talk about situs. Situs is the laterality of fetal organs. If you cut yourself in half, your brain will be identical, your arms are the same, probably, your legs are the same, your thorax and your abdomen don't follow those laterality rules. Okay, you got one heart, it kind of sits over this way, you've got 2 lobes of the lungs here, you got 3 lobes of the lungs here, you got a liver here, you got a spleen here. So everything is kind of symmetrical, but not in the middle. Situs solatus is the normal arrangement of the abdominal organs and vessels. Why is that so important? Well, because the inferior vena cava is going to come up, and it's going to come through the liver, right? And it's going to join into the right atrium. What if your liver isn't here? What if it's in the middle? What if your lungs develop, they didn't develop in the right way? This IVC's got to meet that right atrium. If it doesn't, we're going to have cardiac problems of some way or the other. It's designed so that there's this perfect flow of blood in. So right-sided structures normally are the morphologic right atrium, the liver, and the IVC, among other things, okay? Left-sided structures, the left atrium, morphologic left atrium, the stomach, and the descending aorta. The reason we use the stomach, we can see it well, and we're used to doing it because for abdominal circumference, okay? If the stomach's on the left and the heart is pointed towards the left, we probably don't have any situs problems. We probably have the liver here, the spleen here, 2 lobes of the lungs here, 3 lungs here. If you don't, you got problems and we're sending this kid out. Okay, that's what we are figuring out here. At what point do we hold them or fold them? Here's our options. We're doing a 20-week scan. Everything appeared within normal limits of the heart. Number 2, I couldn't see it very well, so they're gonna have to come back. Number 3, something was wrong. The minute something is wrong, we're not going to evaluate, unless you do fetal echo, we're not gonna do that anymore. Our role then is to say, fold them, we're going out to a tertiary center. Okay. So that's what we're doing in screening. Situs inversus is the mirror image, okay? Well, what happens in a mirror image? It's just backwards, right? I mean, just backwards. That's always fun to start scanning someone and then it's not correct. But because everything is in the correct places, just backwards, it's not a very big incidence of congenital heart disease. Here's our problem. Sinus ambiguous, meaning heterotaxy. It used to be called asplenia, polysplenia. Now we got organs anywhere. And it's associated with complex heart disease. So if the first thing you do is in your OB heart exam is to do your situs, and the situs is incorrect, get them out of there. I mean, it doesn't mean you don't finish your exam because it's interesting, but they're going out, right? Option number 3, it's going to have heart disease and you don't need to figure out what that heart disease is. We are screening it. So we do the best we can, but we're gonna fold them on that. How do you do situs? Everyone by now should have dual image on their machines. If you don't, get a new machine. So you take a dual image, and the reason we do dual, so I'm gonna take an image of abdominal circumference. We got our stomach, right? Then I'm gonna quickly move up and take a transverse heart. Now if I do those dual image, they're right next to each other and the baby didn't have time to move. And then if I write baby's vertex on there during this picture, because they could change, okay, during this picture, if I write the baby's vertex, then I have to do my little and I have to figure out which is left and right. But we have to do that. You can't just take the picture and say vertex. You have to figure out, was this correct or not? This is a good way to start your fetal heart exam. Get that out of the way, because you have a lot of problems otherwise. So take this one image, the dual, make sure you put on there, you don't have to write stomach and heart because, I mean, we know that. But if baby is vertex and then you figure out which way is the kid lying, use your little Barbie doll or whatever you want to do. So to do this, take a dual image of the transverse abdomen at the stomach level and the transverse thorax, and you have to see the interventricular septum. You can't just see a blob of black on your screen, because what we are trying to do is say, which way is the heart tilted? The heart's going to be tilted, and the middle of the heart is the interventricular septum. That's what tilts. That's our axis of the heart. So I don't care if you see all the valves perfect or not in this one picture you're going to take. You have to see that interventricular septum because you have to see which way it's going. And then you have to prove to yourself that it's going towards the left, and then you can move on. Label fetal position. Make sure your interventricular septum is clearly seen. Now you're done with one of the 5 things that we have to do for fetal heart screening. 4-chamber view. Back in 2003, your White Journal came out with this article, the 4-chamber view, and it said the 4-chamber view is the basis of the cardiac scan and a screening exam for congenital heart disease. The technique is simple, easy to reproduce, and with careful standardization, and get this, of the elements that constitute a normal view, up to 60% of congenital heart disease can be diagnosed. What are these elements? Now we got to go back, what do you mean? 60%, number one, that's too low. We're not doing our job. Anyone AIUM members in here? AIUM is, you're probably STMS or ACOG or something on that order. There was an article that just came out, and I printed it off if anyone just wants to look at it. And it just came out, it says screening for congenital heart disease, and it was just brand new in the latest journal. And it just talks about some of the screening. When you get to the end of this article, they talk about some of the anomalies, and then they get to, we have to do cine loop sweeps. You know, you have to do everything in cine, or they would like you to. Eventually, we would love to get to that, but we're not there yet. And we have not been allowed the time in our exams as sonographers to do that, nor do our reading physicians have the time to look through and the responsibility of every single loop. So these 5 views are going to give us the permission to take these still frames, which isn't ideal, but we don't have ideal circumstances. We're going to go back to what elements are we talking about here. And we're going to go back and use our ISUOG practice guidelines. It's going to be our standard of care. And then out of these guidelines, I picked out 10, there was about 10, of the elements that we need to see, and those are on the back of your card. These are when we go to our scanning sessions, you need to find all of these things. Now, does everyone's 4-chamber view look like this? Isn't that wonderful? Look at the trabeculations in the right ventricle. So we're talking about the apical 4-chamber view, right? There are different types, and the literature will talk about different types of 4-chamber views. So when you talk about an apical 4-chamber view, this is a word that we picked up from the oxygen breathing world of pediatrics and adult. When we do a 4-chamber apical view, we put our probe like this, down here. And the tip of our probe, the first thing on the top of our screen, is going to show the tip of our apex. Why are we down here in the oxygen breathing world? Because the lungs have expanded. In the fetus, the lungs are not expanded yet. And the fetal heart is going to sit just like this. So when we do a transverse view of the thorax, you are seeing it's designed perfectly for us so that the 4-chamber view is absolutely perfect. So here's our heart sitting. So we're not coming from this direction anymore. We're coming straight across. Okay, and we're good at transverse views. What do we do with our BPD, right? What do we do for abdominal circumference? So getting a 4-chamber view, a perfect 4-chamber view, we're pretty good at because we're really good at transverse views. We've done those for years. If you have a complete transverse view of the fetal thorax, the apex, depending on where the spine is, okay, is going to be seen, apex and the spine. If the apex is the closest to the top of your screen, it's called an apical four-chamber view. If the apex is pointing down because the spine is over here or up, it's called a basal four-chamber view because the base of the heart is the first thing that the beam is hitting. Apex is first, base is first, doesn't matter. We don't even have to know this, but just because it comes up, especially if you're going to take boards ever, all these things are now being named specifically. If it's straight across, which is a lovely view too for interventricular septum, it's called the long axis view, and sometimes literature calls it the subcostal four-chamber view. So it doesn't matter. We will probably need 2 to 3 of these views in order to see all these elements. You're not going to get what you need in one picture of a four-chamber view. Get over that. You're going to need 4 pictures or 5 sometimes, depending on how good you get them. In order to document these elements, you have to start with the perfect four-chamber view. None of this is going to work if you are off angle. What is a perfect four-chamber view? You have to label fetal position. You have to include the fetal spine. Okay, we love to zoom, and by all means zoom when you're looking at that heart. Don't cut off the fetal spine. Why? Because it's a constant. It's not going anywhere unless we have major skeletal anomalies, okay? It's gonna be in the back in the middle, right? You can judge the axis of the heart and the position of the heart and the lungs by where the spine is. So you can't cut that off. You're gonna mag, just leave that on, okay? If we're in a true transverse view, we should see ribs coming around this way. Now, we all know if you've ever scanned an abdomen or a liver that our ribs go like this. Why? Because our lungs are inflated, not in the fetus. So now we're up like this. So if you see a rib here and a rib here, and they're long, you don't get the railroad tracks look, you know, you're transverse. If you're transverse, the apex should be in this position. You should get a view that looks like this, if you're truly transverse. Well, you can be a little bit like this, 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 but we're good at this, so this isn't a real problem for us. So look for the 2 complete ribs. The ventricles now in this position will be elongated. You will now be actually seeing down, here's our four-chamber view. Now our ventricles are long and our atria are a little bit shorter. Now we are seeing this exact position. It's like this. If we're transverse, this is the view we're going to be getting. So we want elongated ventricles. The interventricular septum has to be clearly seen, which means you might have to come at it a little bit sideways. Okay? When your beam hits this, we're using our lateral resolution to view the sides of our interventricular septum, and we're going to do a little bit better if we go off a little bit. Come over to the side. You just see the septum a little bit better. You have to see that because you have to know which way our axis is. So that's our four-chamber view. That's our perfect view. Do all these and we have our perfect four-chamber view. We've already done situs. We're moving on to number 2. Let's say we take a picture of what we think is a pretty darn good four-chamber view. Just look at it. Look at that view, whatever you took. See if you can determine the cardiac axis. So the cardiac axis is how the interventricular septum is lying, how the heart is deviated. Is the heart laying like this, or this, or this? Where is our interventricular septum? So we need to know that if you look at the spine, which is why you can't cut it off, and you look at the sternum area, okay, right up here, and draw a line or an imaginary line in that area, bisect that by 90 degrees, bisect that, then draw a line down the interventricular septum. This should be about half, 45 degrees. What literature will say, 45 degrees, 25 to 65 degrees. Your heart should be laying like this. This means everything looped normally. You got 3 lobes of the lung here and it's pushing it over. Everything went great in this. It's telling us about the development of how this heart developed. So if this axis is good, you're done. We're going on to our next thing in the back of the card. We're looking for that axis. Now, when you're looking for the axis, take a quick glance at this picture. Now, you've got the mother's 2-year-old's triplets, running around your legs, pulling on the cords. Okay, this is the world we live in, right? That's my world. When you do that, it's hard to evaluate all this stuff. That's why we have it all written down, evaluate, evaluate. If you see all of these things correctly, you can't have a major, plus your other views, you can't have a major congenital defect, heart defect. You can't, if all of these are done right. Take a look at this picture and imagine you're scanning super quick. You know, maybe your eye goes to the teeny little bit of fluid, which is probably within normal limits. And then you start drawing your lines. This is over half. Not good. Something's going on. But man, that 4-chamber view looks pretty normal, doesn't it? I mean, heck, I got an interventricular septum, I've got my valves. It's kind of tilted that way. This is a persistent truncus arteriosus with that. This is terrible. And it looks pretty darn normal in this view. So what this means is that truncus arteriosus never divided in the middle. So it didn't twist either. It never divided. There's one, it's persisting as a truncus arteriosus. Terrible defect, and that can look pretty darn normal. So we have to look pretty closely for what this axis is. Because if the axis is wrong, something went wrong. Something going wrong will change something, right? So if your axis is wrong, but you can't find anything else, but your axis is really off, send them out. Okay, this is a very important part, is where this axis is. And here's another clue. This is the same picture. I just twisted it on my screen. So here's my spine in this picture, and I twisted it so it's over here on this one. So here's my spine. Look at that, that's even got a nice little, to tell me right where the sternum is, right? And if I draw my line here, whoa, that is way over. This axis is way off. And if you just visualize that, you can kind of even just see it. This is way off, that's not here. But the reason we can see it well is the spine is straight down. Why? Because we are staring at a box, the screen, right? And so we've got perpendicular lines here and perpendicular lines here. If the spine is down and the sternum is up, our eyes can say if we're too far this way or too far this way, right? And that happens all the time. So what happens when the baby moves and now the spine is over here? Now I'll take a look at this view, and I'm not going to recognize very easily that not as easily as this. I mean, you look at that and it goes, whoa, that thing's way over. Okay, I'm not going to miss that. But this one, I don't know. It's harder. So remember, when the spine isn't directly up or down or side to side, you're not going to recognize axis problems as easily, and you have to think about them a little bit more. So when we look at this one, whoa, it was way, way over. Okay, there's a problem with this. And then this one, I have to almost draw it to see the problem, to make my eye really see that. So just be aware of that. When we stare all day at something like this, our eyes do better when things are aligned the way our box is. You know, we can be tricked if it's not aligned that well. So now we're going to talk about looping, because this was, something didn't go right. Something didn't turn the way it's going to turn. So here's our pericardium again. When we talk about why is this happening, why is our axis wrong, the specific embryologic event that results in an abnormal cardiac axis, this is a recent article by Abu Hamid, okay, and Shawi, is not known. However, an over-rotation of the bulboventricular loop, when we turned around the big ventricle thing here, has been proposed as the underlying mechanism. The most common anomalies that result in left heart deviation, okay, now we're too far to the left. The most common anomalies are from tetralogy of Fallot, coarctation of the aorta, and Epstein's anomaly. I don't care that you know what those are or not. The most common anomalies with right axis deviation are double outlet right ventricle and atrioventricular septal defects. All I'm saying is defects cause axis rotation. So that's, axis is extremely important, and don't get tricked by it, okay? But we've taken one picture of the heart. We took a stomach, we took a picture, then we erased that picture, took one image of the 4-chamber heart, and we immediately looked at axis. Done. It doesn't take that much time. Just get a good picture. Then we're going to take a peek at this and we're going to go, how is the position? Axis is one thing. Axis is how that interventricular septum is. Now we're talking about how is the heart lying in the chest. It can still be lying right here. It can still be lying straight like this, but pushed over here. So it's got to be 45 degrees here, but it could be pushed over here. So we want to know cardiac position. So look at your same picture and say to yourself, is 2/3 of the heart in the left hemithorax? Draw a line, just look, 2/3, okay, done. We're off to number 4. They don't have to take forever. Now we're going to look again, the same picture you took. You got one great picture, and we're going bam, 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 and checking these off. Cardiothoracic ratio. Basically, the heart should occupy about 1/3 of the thorax. That's it. Chop it up, can you put 3 of them in there? Okay, it should be about 1/3. If you're going to write your boards, or if you're going to get really technical about it, there's 2 ways to do it. A cardiothoracic circumference can be used sometimes, and now you're drawing a line around here, and how long is this line compared to this line, right? The circumference. That can be measured, and your machine can do it. And normal is about 0.45 at 20 weeks and up to about half. Okay, but that's the circumference, that's the length of these lines. Or you can do a cardiothoracic area. I don't do either, I look at it. We're not doing fetal echo, we're doing fetal heart screening. Or they can talk about the area. That's why these numbers are different and they can be confusing in the literature. Sometimes the literature says, oh, the CT should be 0.25, and another says 4.5 or 5. So just because sometimes they're using different measurement calculations, that's why you're going to get different numbers in the literature. Basically, the heart should occupy about 1/3 of the thoracic cavity, and take a look at it. If you have a big heart or a little hearts could be due to hypoplastic heart, which is a cardiac problem, or you can have a huge heart that's big because we have a navy fistula or something on that order. It's wrong. Whatever it is, if it's not that, get them out of there. Chamber size. We still have one good picture we're looking at. Get one good picture and go bam, 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 check, 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 check. So it's not going to take you forever, especially as we get better. So this is very important. The right ventricle, okay, in a 4-chamber view, perfect 4-chamber view, perfect ribs around it, okay? The right ventricle should be equal to or 20% larger than the left ventricle. It is absolutely illegal for the left ventricle to be larger than the right. Something is wrong. Flow goes through the heart in certain ways with these shunts that we're going to get into in the next lecture. It goes certain ways because of the shunts and everything. So hemodynamically, if the right ventricle is a little bit larger or about the same than the left ventricle in this measurement technique, then that's correct. Hemodynamically, we have the blood going in the right ways, which is what we're deciding, right? If a valve was too thick, that didn't absorb well enough and it's too thick, so now we have an aortic stenosis or a pulmonary stenosis or something because that valve is too thick. The flow has to start redistributing itself through the shunts in the heart, and the sizes are going to be different. So how can you do it? I don't measure these in screening. I do if I would do a fetal echo, but in screening I eyeball them. Is this inside to inside with the valves closed? Is this about the same or up to 20% larger, especially later in pregnancy it'll be larger, especially later in the 3rd trimester? Are they about the same? If the left ventricle is bigger, then readjust. Make sure you didn't come across it funny. And then you have to be really worried about potentially a developing problem of hypoplastic heart develops through the pregnancy. Aortic coarctation develops through the pregnancy. We don't have to know all that, but we have to know that it's possible and how to look at it. So there's our chamber sizes. The atrial sizes are about the same. So I'm talking about sizes. So check, 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 check. Size matters because when the structure of the heart is normal, the volume of blood flowing through the chambers will be normal. When the structure changes, such as in valvular stenosis, the size of the chambers will change as the volume of blood must redistribute, just like I said. So the shunts in the heart play a big role in this, which we haven't had to talk about yet. Now we're done with number 9. Now, moderator band. We always talk about, got to see the moderator band. Why? Because the moderator band lives in the morphologic right ventricle. The ventricle that started, that should be on the right. Amazingly, sometimes the right ventricle can be on the left, associated with the left atrium. It's called corrected transposition of the great arteries, and it's rare, but oh my gosh, we don't want to miss it. So we have to see that when we take this picture, and I say this is the right, because I did this, and I say this is the right-sided ventricle and the left-sided, the moderator band is a band of tissue that crosses over, and we can see it pretty well, especially with the apex up and down, because our beam is going to hit it. Okay, our axial resolution is going to hit this easily. I started thinking to myself, well, what the heck is that thing for anyway? You know, what do we need a moderator band for? So just out of curiosity, I researched it, and it's also called the septomarginal trabecula. You don't have to know that. It's a muscle band of heart tissue found in the right ventricle, never in the left-sided ventricle, if they're correct. It's seen near the apex and extends from the ventricular septum to the base of the anterior papillary muscle. The moderator band is important because it carries part of the right bundle branch block. Now remember, we're not only talking structure, we're talking about electrical connections. This electricity has to be going through the heart. You have to have your SA node and your AV node, and all these pathways have to be. Well, for some reason, the left ventricle figured it out and doesn't need a shortcut. But the right ventricle couldn't figure it out and needs a shortcut in order to get electrical stimulation across here. So that's what the darn thing is for, and that's why it's always on that right side. Now we have done situs, cardiac axis, position, cardiothoracic ratio, chamber size, and moderator band. Now we're going to the crux of the heart. Why do we look at the crux of the heart? This is our atrioventricular canal that had to form with these endocardial cushions, with this intricate little way it had to do. So we're coming together with a whole lot of anatomy. Interventricular septum, interatrial septum, mitral valve, tricuspid valve, all of that happens in here. And remember, it doesn't go right in 50% of the cases with trisomy 21. So, and that's going to be our most commonly found chromosomal anomaly, so this is not all that uncommon. How are we going to look at this? When you look at the crux of the heart, there are two things that you have to see. So I could have made 11, but it didn't sound as good as 10. So I just left number 7 has actually two things, okay? The tricuspid valve is married to the right ventricle. In this marriage, there can never be a divorce. You guys know about geese? They mate for life. These things mate for life. The tricuspid valve is the right-sided heart valve always. And how do you know it's the tricuspid and not the mitral, which happens to be a bicuspid valve? Because the tricuspid valve inserts a little bit closer in the interventricular septum to the apex than the mitral valve. And you have got to see that. That is one of the things you have to see. Because if they insert like this, that's normal. If they insert like this, it might only be one valve, and you've got an atrioventricular septal defect, a canal. This is something we have to see. The other thing we can see in order to tell in our minds we don't have this, okay, is a little bit of the interatrial septum called the septum primum in this area. Now, when I see this relationship, I've got a little bit of tissue here, mitral's coming in here, tricuspid's a little bit lower, there is no defect in there. No major defect. You do not have a complete atrioventricular canal. You do not. You can't, okay? It can't work that way. So we're gonna look at the tricuspid insertion. It's sometimes very close. And a lot of time you see it a little bit off axis like this. Straight up and down, we're hitting with axial resolution on the valves if they're closed, but lateral resolutions on anything here. Tilt your beam a little bit. Come in this way or this way. You have to identify that the tricuspid leaflet inserts more apically than the mitral valve. You have to. Very, very important. Otherwise, it will look like a normal 4-chamber view, and if you didn't look for that, you missed an atrioventricular canal defect, and sometimes you can drive a Ford Ranger through those. They can be big holes, and they are not that easy to identify as you would think they would be. This is a very thin area, and sometimes we get dropout in this area, especially when you're straight up and down on our beam. So again, come over a little bit, because this area commonly looks like a VSD. Okay, that's not uncommon to look like a VSD in this area. So try and go to a subcostal view. Try and move it around a little bit. That might be a better way to see it. You might not see the valve insertions, but you're going to see this septum, because we are looking at this crux of the heart. Here's this one example I have of a corrected transposition. So believe it or not, we don't see the moderator band here, but what we do see is the tricuspid valve inserting into the septum closer than the mitral valve. This is absolutely wrong. You miss this, and it is wrong. This is the right ventricle attached to the left atrium. It's called corrected transposition. This is the left ventricle connected to the right atrium. That's why we have to see this. We wouldn't have missed this anomaly. We don't have to know what it is. But look at the axis of this. It is wrong. Okay, it is straight up and down. So even if you say, oh, I'm worried about seeing those, other things will be wrong. These are meant to build on each other. This is meant to build on each other. So if you don't see it in one, you might catch it in another. That's why we have so many. Atrial septum primum. This is the other thing we're looking at, this little bit of tissue here. If you can drive a truck through that, this little bit of tissue isn't here. So that's gone in the AV canal defect. So this is what one looks like. Now this is one big valve across here. Those endocardial cushions just decided not to touch each other. So we can drive a truck through this. But that is not all that easy to see. This is an 18-week one that was missed in my lab in Fargo. She came back for something else, and the heart was bigger, and then they noticed this. Okay, so this is a terrible defect, and we can't miss it. But look for those two things. Got to see a little bit of that primum, because that's got to be there, because that's got to be that connection. Fossovallus flap. This is something we see in motion. The fossovallus flap goes, the blood is coming from the right atrium into the left atrium, right? So the flap has to be seen in the left atrium. Now this isn't all that important. If you're going to forget one, forget this, because if the flap is going the wrong way, we have serious problems, okay, serious problems, and you're probably not going to miss the serious problems. Pulmonary veins. We want to see pulmonary veins, at least one. Because if you see one, okay, then all four of them didn't decide to take a different route. Okay, so we want to see at least one of these pulmonary veins. How easy are they to see? Okay, well, when you look for them, they get a little easier. Here's one coming in here, left atrium, okay. Here's two coming into the left atrium here. Here's a couple coming in here. Now this is color with a low scale setting, and that's, that's as beautiful as you're ever going to get. And here's a couple more coming in here. We just start looking for them, and this is why. Another new article that just came out. All this is there's a new article, and it came out in the AIUM Journal 2016 in June. And all it talked about was anomalous pulmonary venous return. Anomalous meaning, I don't know where I'm going. Wrong. Pulmonary venous return. Okay. And they talked about total anomalous pulmonary venous return and partial anomalous pulmonary venous return. So sometimes all of the pulmonary veins say, I'm not going into the left atrium, I'm just not, I'm going to go somewhere else. And they dump into the superior vena cava. And the superior vena cava drags them through the right heart again. And that's fine, because we can cross over the fossovallus and get to the left. But not after birth. We die. So these are important. Even if you get one coming back, you probably don't have total anomalous. And we're a little bit better. We can't be expected to see four of them. You're never going to see the four. So the good thing about this is extremely rare and generally not found in utero. So it's not something that you'll probably end up in a lawsuit over, because it's very, very rare. However, we are stepping it up these days in fetal heart. Even with screening, we're stepping it up. We need to start adding some of these stuff in. Maybe that'll be clip someday, maybe it'll be color, maybe it'll be Doppler, whatever. It's not there yet. But basically, they are saying we need to start looking at these things more. So pulmonary veins are something, just look for them. This basically is just from this article, and they say that color flow can be helpful, but then you have to be very good at how you set your settings. Here's an example. Here's a 4-chamber view. This is the left atrium. Do I see any pulmonary veins? No. Readjust your image because baby squirms. Oh, I readjusted. Okay, I see them. Done. Just make sure you see them. Here's another one. 4-chamber view, left atrium. I don't see them. Readjust. Still didn't see them. Readjust. Still didn't see them. But what I did see as I moved up into the RVOT view was another vessel that wasn't supposed to be there. That is a sac where these 4 veins came together and decided to form a little sac and then dump into the superior vena cava. You don't have to know that. It's just not right. No pulmonary veins could ever be seen here. Interestingly, she was referred to MFM because her first child had total anomalous pulmonary venous return. And her second one did too. We'll go to the last thing, interventricular septum. Ventricular septal defects are the most common form of congenital heart disease because when this septum is forming between the ventricles, there has to be this absorption and reabsorption process to thin it out to where it has to be. Sometimes it thins out a little bit too much and we get little holes through it, usually diagonally like this. We don't really care about those. Those are these little VSDs in this muscular area. We care about the VSD that happens because the truncus arteriosus didn't grow in from the sides and twist normally. That's the VSD, because if that happens, it can't connect here. If we don't twist normally, we're not connecting in that spot. So what's that tell us? We have some major problem. That's the VSD that we're going to be worried about. This is called membranous VSD. Muscular VSDs can occasionally be seen. It's just in the middle of the septum coming back and forth. They usually resolve themselves. 20 weeks of pressures are pretty similar between the right and the left, so you don't see the color flow, and they can be teeny little. They're rarely detected unless they're 2 to 3 millimeters, which means they're pretty darn big, 20 weeks. This is the one that we're worried about. We want to see that this is one big vessel coming in. This is a persistent truncus. This truncus arteriosus never grew in, never spiraled. Didn't happen. So what happens is now this one big vessel is sitting right over top of the interventricular septum, and this vessel is getting blood from both chambers. The left ventricle only should be sending blood out to the aorta. The right ventricle should not be sending blood out to the aorta. Here's one again. It's called an overriding aorta. Here's the septum. The septum should connect here, which is what we look for in the LVOT view in the next lecture. In the 4-chamber view, we're really not moving up yet. We're not moving up into our LVOT view coming like this. We're still down in this view, and you can miss some septal defects that are higher. That's why we do our outflow tracks. But in the 4-chamber, you want to see as best you can that this is intact. That's what we're looking for.